Lovely people, happy Friday. As you may have seen, if you well, not if you, but as you have seen, since you have hit the Zoom link on the email, we have a very, very, very special setup today, one that replicates the very origins of CP solvers. I'm thrilled that I get to go discuss with Sharmin. And if that is not unfamiliar to you, kudos to you. You are a CP solvers consumer through and through, because you know that for gosh, 2+ years on VMR. Sharmin and I would co-discuss on Thursdays. It was the very inception of what currently happens on Thursdays. And yeah, I'm just so thrilled that I get to co-discuss with you, my friend, and partially a little bit of revenge on Reza for having stolen you once a month on Wednesday. So yeah, let me hand the mic to you to say hello, and then maybe we can introduce our friends who are helping us make happen.
Absolutely. It's such a privilege to be here. Thank you for having me on a Friday. And Prof Rest shoes are very big to fill, so I will not even attempt of doing that or interrupting you, Robbie, for once. But no, it's kind of insane. Like CP Solver started in 2018. Can you believe it? I still internally feel like that baby resident, but I guess I'm a grown up now. But who knows? But it's always such a joy to learn from you, Robbie, and discussing it since I was an intern. So looking forward to this session. And we are very, very lucky to have like our CP Solvers team members and Academy members who are doing scribing and doing teaching points today. I'll pass the mic to them to introduce themselves.
Kusha,
Hi,
oh, there
everyone.
you are.
Okay, I'll go first, then Julia will follow me. So, hi, everyone. I'm Patricia. Yeah, I think I don't need to present myself, I guess. But I am from Cameroon and really excited to scribe for this session. I can't wait to learn a lot from you guys. Thank you.
I'll go. So, hello everybody. My name is Julia. I'm a medical graduate from Germany, and so glad to be back this week. I felt reminded, like in the discussion we had before, we were talking about beating gravity, and I just got to see my sister in Switzerland, and I tried to beat gravity because it was so hilly everywhere, and it was just so. So kudos to everybody that can not only run on a flat ground but does beat gravity, guys. Keep up.
You're amazing, Julia.
So yeah, I'm very excited for today. It's such a special discussion, I feel. So let's get started.
Yeah, and to top it off, Julia, we have a first-time guest presenter, and Zach, your case has not been hyped as much as many cases in the last few weeks. I hope that's not added pressure on you at all, but your friend and colleague Zachariah has been eagerly ramping up today. And so maybe we can hand the mic to you to introduce yourself, tell us a little bit about yourself and how you know Zachariah.
Oh, whichever.
Oh
Senior or
yeah,
junior.
I'm referring to you, my friend.
Okay. Hi, everyone. My name is Zakaria, and I'm doing my second year of what you guys know as foundation training. Second year of internship at Tigerberg Hospital in Cape Town. I was introduced to clinical problem solvers through Zakaria, and he's been pushing me to present a case for now for over a year. So it's long overdue.
We're so happy that you're here. Tell us a little bit about yourself outside of medicine. What do you enjoy?
So outside of medicine, I do the odd running, tennis, pedal tennis here and there. Yeah, that's about it. Work is
Amazing.
busy.
Where do you see yourself going in medicine? Do you have a path that you want to trot, or is that still TBD?
So like Zakaria was saying, my dad's a physician. He's a pulmonologist, but
Oh,
he does mainly general medicine, and he loves a diagnostic challenge.
mm.
So hopefully in that direction.
I think you'll find yourself very comfortable in the situation of loving diagnostic challenges. I know you have one in store for us today, and we're ready to kick off whenever you are, and excited to hear Sharmin's thoughts.
Okay, sure. So I've titled the case When the Pressure Rises, and we'll reflect on that later. So the chief concern, I was called to the ward to review a patient with new onset haemoptysis. And that occurred in a 30-year-old female who was admitted overnight. So the history of the presenting illness, she had 2 episodes of coughing up blood, approximately 2 or 3 mils, mixed with some sputum, and that was collected by the patient in a small tissue of hers. She also endorses that she's had dyspnea, which was progressive over the past 2 months, and we graded it now as New York Heart Association class 3 to 4. She's now quite breathless at rest, sitting upright. She also endorses the following symptoms: bilateral lower limb swelling, orthopnea, paroxysmal nocturnal dyspnea, facial puffiness, weight loss over the past 2 months. She endorses that her clothes are now a lot looser. She also endorses night fevers, a cough which was dry initially and now the haemoptysis, and of note, 1 to 2 episodes recently over the past month of epistaxis. She denies any rashes, any paresthesias, and no other systemic symptoms. And I'll stop there for the first aliquot.
Oh, wow. Thank you so much, Zakaria, and thank you so much for joining us. As soon as your title said the pressure rises, my pressure started to rise too. So I'm excited for this. What a good start. And what I'll do, I'll just talk a little bit more generally about haemoptysis and then pass the mic to the one and only RG to layer on. So whenever I hear the word like haemoptysis, the 2 things that I want to know is like, wait, is the patient stable? And second, am I dealing with the mimickers of haemoptysis? Oftentimes things like a hematemesis, a GI bleeding, and also epistaxis can mimic haemoptysis. So that is like 2 things to keep in mind as you get called for haemoptysis. The second thing you always want to do is to make sure, are you dealing with like a large volume or small volume? Meaning, is the patient clinically stable? So blood pressure, vital signs like tachycardia, and also just in terms of like their oxygenation, that'll give you a clue as to like how much time do you have to be able to kind of think more diagnostically, or you need to manage first. Oftentimes in the world of haemoptysis, when people come in, they have like a right-sided lung mass or something that you have some clues as to where the pathology might be. So if you're dealing with a large volume, you want to make sure that lung goes down because you don't want it to spill into the good lung. And in terms of like kind of like thinking, let's say like, the patient's small, like stable, and we're dealing with like maybe small amount of haemoptysis, your no misdiagnoses tend to be the bad bleeders, like anything that causes atrial fistulization, anything that would cause hemodynamic instability. Those things most often happen like post-surgical intervention. And the most common things we often see is like kind of the pressure rises on the left side of the heart, causing like more venous pressure. And oftentimes, like, you can have like haemoptysis or like a sputum with like streaks of blood. And then there's also all the diseases that oftentimes in the clinical reasoning realm, we love that form in the world of like capillaritis, which is like the vasculitides and many other sometimes like parenchymal diseases lie as well. So that's how I kind of like conceptualize haemoptysis. RG, what do you think of this case so far?
Yeah, no, I love that. I think a question is, are you being fooled, and how serious this is very wise. And I think it's tempting not to analyze this case in the broader context, because I think most people who have haemoptysis have just haemoptysis, and the fact that she has so much else going on is very, very intriguing. And the fact that she's also having epistaxis took me to a space where I'm just trying to really understand something from a very simple lens, which is, why is she bleeding? And I think if we adopt that approach in a very simplistic manner, I think most of the time when people are bleeding, they either have an entity that will diagnose by analyzing their blood, be it low platelets or high coagulation issues, or they might have a blood vessel wall issue. And I think whenever bleeding is localized to a specific anatomical area, we tend to assume that there's something structural. And I think that's probably the default assumption with haemoptysis, right? Is you're like, the patient's bleeding, but they're bleeding just in their lungs. So I'm going to look and I'm going to see something structural like a cavitary mass or elevated filling pressures from heart failure. But the moment that you have bleeding elsewhere, you're like, okay, am I dealing with a rare systemic disease that affects the structure of blood vessels? Or is this an issue in the blood? And I find that to be really, really intriguing, because I think most haemoptysis is not a thrombocytopenic coagulopathic issue. But what about the combination of haemoptysis and epistaxis? And I think that makes it tricky. Okay, I'm curious, what is your instinct, Elisha? I mean, are you feeling like you're going to have a blood issue, or this is going to be a structural blood vessel wall problem?
I'm not sure.
Yeah.
I I think like, given like her volume overload and everything else, there is some, there's like some systemic diseases going on that is like causing her to have, I think like she has heart failure. Is that it?
Yeah.
Like heart failure, and whether that is like just kind of a red herring, and the epistaxis and the hemoptysis is another a new syndrome that she's experiencing, or are they both the same and she just experienced she at times thinks this is hemoptysis but she thought it was epistaxis. I'm not sure where the issue is. Like there are like your point, there are many diseases in the world of CPS that lives both in your like sinuses and nasal, and also it causes like kind of vasculitis, so it's hemoptysis type things like so it's hard to ignore those. However, I think like in all comers, you're right that common things being common, like bleeding disorder, might be the one that we're dealing with. But I'm not sure which direction this case will go.
Yeah, neither am I. I think it's amazing. If you just have epistaxis and hemoptysis in a young woman, you're like, this is ANCA-associated vasculitis until proven otherwise. But so few of those people have heart failure symptoms, and I think that makes it a really, really tricky combination. I'm just open to the small possibility that heart failure may be completely noise here. And it's very rare for heart failure to be noise, but high output heart failure from really bad anemia can be a complete distractor. So if she's just bleeding and her problem is just bleeding, and that's the core issue, we can be pulled towards a high output cardiac failure causing from anemia that may just be a consequence of this. So I think if we try to simplify it, like we know she's bleeding, that's abnormal. We have a high suspicion that she has heart failure, that's abnormal. And how could you link those two in a very simplistic way is maybe she has high output heart failure from anemia. But where I would be starting, I think, is to say, what are the scariest causes of heart failure? Does she have pericardial effusion? Does she have a rapidly progressive myocardial process? Or does she have an endocardial issue? And I think the interesting overlap between endocardial issue like valvular disease is the turbulent flow across a valve can cause an acquired von Willebrand's deficiency, which can cause somebody to bleed. So I think there's so many cool ways you can connect the dots, but I'm really curious, like practically, what do you think would be most helpful to like make progress next?
Yeah, I think like sometimes just being at the bedside and looking at what people are calling hemoptysis is really helpful, right? Like I've been called and it's just like streaks of blood. I get called and it's like absolutely blood. So I think like that will help tell you a little bit about urgency of the situations. And then I think the other one is like always reviewing the med list. If she is, someone 30 years, quite young, but oftentimes like things like AFib goes with heart failure. So if she's on anticoagulation, that might be your answer as to why she's bleeding, if there's a lesion to that. And then like getting some labs and a little bit more data about both background of her heart failure to better understand what was that thought to be etiology in a 30-year-old to have heart failure. And like some of your basic coagulopathy, if she's not on an anticoagulation workup, I think that would be kind of my next step. And also like a physical exam. I kind of missed that, right? That I would look for just degree of like kind of like a volume overload. Are you seeing any rashes? Like if you're in the world of like ankle vasculitides, petechials, any of those things that can help you make you a little bit more progress. And oftentimes just like looking inside a note. I don't know where you gotta find that scope because it's always missing in the hospital. Is there any evidence of like old bleed there to help you make progress? Like, is this someone who's had evidence of old epistaxis before or not? So that's where my mind is going. What about you, RG?
Love it. No, I'm same way. And I think all that data is gonna help us stratify the three themes of this case. There's bleeding, that's a fact. There's likely heart failure, that's almost a fact. And then there's inflammation with night sweats, fevers, and weight loss. And so I think we'll keep track of those three things, see how they flesh out with all the data that you outlined. I think it's awesome. I can see why this case is being really hyped, Zachary. I'll hand the mic to you for the next aliquot.
Okay, excellent discussion. So for past medical history, she was previously well. She's not on any medications, no significant family history. Socially, she's employed as a saleswoman. She's monogamous with one partner, no children. In terms of her habits, she doesn't use alcohol. She doesn't use any drugs. She has a 5-pack-year smoking history and sexual history, no prior STIs. She's not allergic to anything. So I'm going to get straight into the physical exam. So in terms of her vitals, her temperature was 37.1 degrees Celsius, heart rate of 115. So she was tachycardiac. Blood pressure was 172 over 105. Respiratory rate of 22. So she was tachypneic. Oxygen saturation at 99% on room air. And a glucose of 6.2, which translated to about 113 in the transatlantic measurement, which was fine. In terms of the physical exam, the general examination, she looked quite puffy facially. There was subconjunctival pallor. There was no clubbing, no jaundice, no lymphadenopathy. In terms of the head and neck and ENT exam, there was no obvious nasal bleeding. In terms of the cardiovascular exam, her JVP was elevated. Her apex beat was displaced. There was a S1 and S2 present, as well as an S3 gallop rhythm. There was bilateral pitting edema. In terms of the respiratory exam, she was in mild respiratory distress. She kept on coughing throughout the examination, and I observed some of the haemoptysis. She also had bibasal crepitations or crackles. In terms of an abdominal exam, it was soft and non-tender. There was no hepatosplenomegaly, no ascites. In terms of a neurological exam, a Glasgow Coma scale was 15 out of 15, and there was no focal neurology, no focal deficits. In terms of a skin exam, there were no rashes.
Wow, what an outstanding exam. Yeah, Sharmin, maybe I can just tackle the vitals because I think there's so much juice in them, and I'll leave the exam to you. And I should just to say that I think it seems like we're starting on a blank slate in terms of clues from the medical history, and I think that's a fair assumption to make, but we might have to reassess that if we get more data. But if you just look at the vital exams, vital signs, I'll just make a leap of faith based on the history alone that if you're analyzing these vitals in the context of heart failure, you should really, really worry. And the thing that should make you worry immediately is whenever you see tachycardia in the context of heart failure, your default hypothesis should be that the patient is in sinus tachycardia and they're about to go into cardiogenic shock if they're not already. And there's only two ways out of that hypothesis. The most common way is you get an ECG that shows they're not in sinus and they're commonly in either atrial fibrillation or flutter or some other arrhythmia, in which case now the heart rate is no longer proportional to the severity of the syndrome. It's a marker of their arrhythmia burden. That's the most common scenario. In this scenario, you immediately exit out of that hypothesis, not because of an ECG, but because of the blood pressure. And though patients can have normotensive cardiogenic shock, hypertensive cardiogenic shock is exceedingly rare. Just briefly, the pathophysiology of normotensive cardiogenic shock is due to the perfusion pressure. The venous hypertension in patients with heart failure can be so high that it may overcome a relatively normal arterial pressure resulting in ischemia. But here, with a blood pressure that high, it'd be pretty unusual to do so. So this is a very, very distinct and abnormal pattern. And this analysis is only valid if the patient has sinus tachycardia. So how do you say, like, what is the combination of the fact that the patient has sinus tachycardia, presumptively, heart failure, and hypertension? It's a very, very concerning combination for high output cardiac failure, where the patient is pumping so hard and so fast and circulating their blood volume so effectively that it becomes under higher pressure. So that's a hypothesis that emerges from the vital signs alone, though there are other equally important hypotheses. Most important is the patient has aortic regurgitation. Whenever patients have chronic aortic insufficiency, their stroke volume is really, really high, only for the regurgitant blood to then seep back into the left ventricle. So when you see this combination of things, sinus tachycardia, not confirmed yet here, and hypertension and heart failure, you really should think about those things. High output cardiac failure, chronic aortic insufficiency. The most common diagnosis of hypertension and heart failure is just classic hypertensive heart disease, though those patients do not usually mount as sinus tachycardia. So I'm really eagerly awaiting to see this EKG. If it's an arrhythmia, this analysis is void. If it's sinus tachycardia, I'm hurtling towards making sure this patient's aortic valve is intact, which based on exam it seems to be, but that's not perfect. Or making sure to understand, does this patient have a high output cardiac failure? I'll hand the mic to you, Sharmin, but maybe I can ask Julia if you. Oh, actually, I think Yaz is sharing the screen. So perfect. Thank you. I think Patricia is having some connection issue. All right, Sharmin, mic is all yours.
Yeah, no, that's absolutely brilliant. The first thing that, to be honest, from the exam that caught my eyes is like facial swelling. How many heart failure patients have I seen with facial swelling? I can't really think of. I oftentimes with facial swelling, I think of more like anosarca, and it invokes like the word of like kidney disease or like hypoalbuminemia in my mind. So that is like again like I do think there, as you beautifully said, like high output heart failure is very high on the differential. Then the question becomes like, why is if that's true, and viral valvulopathy is like why? And I think like as you mentioned, anemia, thyroid disease are also good in a young person is good to consider. The other thing that also crossed my mind that I don't want to miss, and someone who has increased elevated JVP, in terms of the right-sided and the pulmonary system itself, is there any elevated pressures in the pulmonary system that is getting transmitted to the right side? And I live in fear of right-sided heart failure. It's like so challenging and it's tough. It's a tough world, the right-sided heart failure. So, like, in setting of like bleeding, are we dealing with a bleeding and clotting disorder? Are we dealing with like pulmonary hypertension, especially in the setting of someone who has like haemoptysis? Are the vasculature affected? Bibasilar crackles don't always mean volume. Is there any evidence of like ILD or something? Are we dealing with like a more inflammatory syndrome? Because the other thing that is bothering me, to be honest with you, Rabih, is her weight loss with heart failure. So there is some influence, as you mentioned, like inflammatory syndrome going on that I think kind of overshadows the heart failure a little bit. And in terms of like the rest of the exam, I think those are the two things that really jumped out to me. Any other thoughts from you?
Not at all. I think that's absolutely superb, my friend. Yeah, I'm really struck by the facial swelling as well. And I think that I just lie. I'm gonna steal your sentence. I live in fear of right heart failure. I think that's such a powerful thing for all of us to upload. As always, I have nothing to add, but just somehow say things with no additional value. So I will stop talking and hand the mic to you, Zakaria, for more information.
Wonderful discussion. So in terms of investigations, in terms of the hematological investigations, we have a white cell count of 12.1, which was normal, a hemoglobin of 7.9, which was low, a platelet count of 154,000, which was repeated, and it came back as more than 300,000, CRP of 168, which was elevated. In terms of a chemistry, sodium of 133 was normal, potassium of 3.5, normal, calcium of 1.93, which was normal, magnesium of 0.78, which was normal, phosphate of 3.28, which was normal. Glucose, as I gave you earlier, was 6.3 millimoles per liter, which was normal. An albumin of 31, which was mildly decreased. An LDH of 478, which was slightly high. Liver enzymes, normal. Troponin, negative. Coagulation studies, normal. In terms of the urinalysis, her dipstick showed 2 plus blood, 3 plus protein. In terms of a UPCR, quantified as 2.4 grams per day. In terms of a urine MCNS, it came back as 0 leukocytes and more than 750,000 red blood cells. And further, in terms of the renal function, her BUN was 121 and her creatinine was 15.6, which was very high, and we don't have any prior baseline kidney function and a GFR of 4. And I'll stop there.
All right. Sorry, I got caught up for me. You said creatinine was 15. Yeah,
1.5.
1.5. Woo! Kidneys enters the chat. So I'll just talk a little bit. Maybe I'll lay the kind of the foundation and ask Rabih to layer on to that. I think in terms of like the CBC, not surprisingly, she does have anemia, and I would personally, in a case that I'm not sure how everything gets related, I tend to want to chase down things a little bit more. So I would love to get a better understanding of this anemia as well. I'm thinking about, is there any evidence of iron deficiency? Are we dealing with hemolysis? Like, I think a smear would be really helpful in this case. So that is something, again, to investigate a little bit further. But I think whatever we do, we have to explain her kidney function. So she has severe AKI with some evidence of like blood, so which opens up kind of a rapidly progressive kidney disease. Especially in someone who doesn't have any prior. There are a couple of things that makes me point to the fact that this might be a little bit acute, but I would love for you, Rabih, to let me know if I'm thinking about this wrong. Is that I often expect if this was more of a chronic, that I would see like more other evidence of like FOS for it to be like a little bit more elevated, like other abnormalities that suggest that this is something that has been more chronically happening. The fact that it's like in this picture of like someone who's coming with hemolysis, I'm worried that we're thinking of we're in the world of like rapidly progressive glomerulonephritis, and that is like kind of our no misdiagnoses, a diagnosis in that sense. And as we mentioned, like with vessels, it makes me think a little bit more worried about being worried about the vessels that are in your pulmonary renal syndromes that both affect the lung with the haemoptysis and on the kidneys. So that's kind of where I'm at. What are your thoughts, Rabih?
I think your pin in the facial puffiness being unusual for heart failure, I think has really borne fruit because the association with kidney disease is really robust. And I agree with you. I think we have to explain this kidney disease and the timeline. It's almost impossible to have such long-standing kidney disease that you have enough muscle mass to even have a creatinine this high. So I think the timing is fairly acute. And yeah, I'm right there with you. I think the momentum towards the kidney has really, really gained. And so the question is, what's up with the kidney? And I think the default diagnosis when you have kidney disease and acute kidney disease or subacute kidney disease and hypertension is a renal vascular disease. And so when you look at that UA, it's hard not to say, oh my gosh, could this person have glomerulonephritis? And that really fits in the theme that you outlined of vascular issues, be it in the lungs, in the nose, and now in the kidneys. I think the only, and then that helps us loop back into wonder about the hemoglobin, which of course might be some blood loss, but may be related to the EPO deficiency that the patient has. But I think we can sort of update our problem representation to say this is an inflammatory disease with a renovascular component that seems to be glomerulonephritis. And then the question is, what do we do about the heart? And I think it's very easy to say that it's easy to remember that most people with glomerulonephritis do not have an S3 gallop and don't have evidence of cardiac dysfunction. But given the severity of her renal dysfunction and her creatinine, her GFR being 4, I see the exception to that rule. So yeah, I think I'm almost ready to essentially say we're solving a subacute glomerulonephritis in a young person, with the only caveat being, are we sure we can tuck in her, I should say, sorry, subacute systemic glomerulonephritis in a young person is, can we really tuck in her heart as a innocent bystander, or is there intrinsic heart disease? And I think when you run the list of no miss possibilities of kidney plus heart disease, you have to make sure that there isn't a pericardial effusion that's augmenting the severity of her kidney dysfunction. And the pericardial effusion as a hypothesis may be both as a result of uremia, but if we're invoking an inflammatory glomerulonephritis, coexistent serositis affecting the pericardium is also very, very possible.
Mhm.
So yeah, I'm not. I don't think we can let the heart off the hook.
Yeah.
But I think the kidney is the weight of it. But yeah, what do you think about that?
Yeah, I was like trying to figure out, okay, what is my Venn diagram of like hemoptysis, heart, and kidneys. The other one I was like, oh, endocarditis for sure can cause like um cardiac issues, glomerulonephritis type pictures, but hemoptysis doesn't quite fit unless like you want to tie that into heart. So I think I'm not ready to let go of the heart yet. However, I think the answer kind of lies in like investigating glomerulonephritis as well. So oftentimes we think about whether, as you mentioned, like a renal board of like ANCA, like that immune glomerulonephritis, whether it's like more immune complex mediated. And I loved the teaching you did about like complement and RLR previously. So I think I would work up the glomerulonephritis here. And I think this is a person to ask renal whether they would consider kidney biopsy sooner than later. She's like 30, but you know me, I always miss lupus. So I have to mention lupus here as well. So yeah, I'm not ready to let go of the heart either. So yeah, we'll see. All right, Zachariah, you have me on the edge of my seat as my pressure keeps rising.
Okay, so in terms of other labs, HIV test, which was negative, hepatitis A, B, and C screen, which was negative, syphilis serology was negative. In terms of a thyroid function, she had subclinical hypothyroidism, hypo. Rheumatoid factor was 10, and normal for our lab was less than 14, so it was normal. The ANA anti-double-stranded DNA was negative. The anti-streptolysin O titer was less than 25. The anti-DNase B was 64, which was normal. The C3 was 1,39, which was normal. C4, 0,26 for our lab, normal as well. ANCA serologies, MPO, PR3, all negative. Anti-GBM, negative. In terms of imaging, we got an ECG, which showed a sinus tachycardia and left ventricular hypertrophy. In terms of an echo, we got an echo that showed mild concentric LVH with a left ventricular ejection fraction of 35 to 40% and diastolic dysfunction. And the echo, all in all, was suggestive of hypertensive heart disease. In terms of a ultrasound of the kidney, ureters, and bladder, it showed normal sized kidneys with increased echogenicity. And in terms of a chest x-ray, I'm going to share the picture with you. Okay. Can you all see my screen?
Yes.
So this was the AP. And this was a lateral. Go back to that.
Yeah, I just share my quick interpretation. I think that you see essentially a central greater than peripheral dense consolidations, which appear to be more predominant on the right than the left. And I think in the context of hemoptysis and the lack of pleural effusions, this would really make you think about diffuse alveolar hemorrhage. So I think, yeah, just to say that again, this is a diffuse process. It's central more than peripheral. There is no pleural effusion, and the patient's hemoptysizing. A default hypothesis would be this is a diffuse alveolar hemorrhage, which is different from a vasculitis because diffuse alveolar hemorrhage can be from also from venous hypertension from the heart, but I think this is probably some bleeding. What do you think, Charmaine?
Yeah, that's very impressive X-ray. Yeah. Do you want me to take the first step or?
Yeah, I'll take a quick crack at it, and then I don't even know where to start, but I think maybe I can just start by trying to clarify what progress we've made. And I think that the heart, as you suspected, Charmaine, the heart's not healthy. It seems like there's consequences of hypertension on the heart, but there doesn't appear to be um, raging pericardial disease or endocardial disease, but the heart itself is unhealthy. And we certainly made that progress. And I think we've also classified the kidney as normal complementemic kidney disease. And the fact that the complements are normal really prioritizes ANCA-associated vasculitis, anti-GBM disease, and IgA nephritis. And it's interesting because the serologies for those things, ANCA, anti-GBM, are negative. And so could you just say, oh, you know what? I have normal complementemic kidney disease. Those are the three priorities. But ANCA and GBM are negative. Does that exclude those diseases? Those are the kind of musings I'm having, but I think the progress we've made is to say the overwhelming probability of this kidney disease is in the glomerulus based on the fact that now we have very likely lung bleeding. There was a small possibility that the patient had post-renal disease causing hydronephrosis because of the height of the creatinine, but I think that's less likely. So yeah, I think the problem really has crystallized into normal complementemic glomerular disease with some associated cardiac issues and epistaxis, which is a very interesting problem space. What are your thoughts on it?
Yeah, yeah, I totally agree. I'm a bit puzzled. One thing I would say, like, negative ANCA serologist doesn't really rule out ANCA. It's not a perfect world. So I think you still need to rely on your biopsy here to completely rule out like ANCA vasculitis. The one thing that I can't really make sense of, Robbie, is like that elevated LDH. Like, where is that coming from? For a moment, I was like, oh, is this kind of lymphoma cryo type pictures? But again, I would expect like low complements in that setting, and we have a normal complementemia. So for me, I think still in this probably like a vasculitis makes more sense. Are there any mimickers that we are missing? Like, does he have any history of like substance use, like cocaine, that can cause, kind of the DAH type pictures? Are there any infections that we are missing? That I need your help with because I know, yes. But I think like things like lepto, I remember like being able to cause DAH, but I'm not sure if like the pattern of kidney injury makes sense with that. Scleroderma is another one to kind of think about in the world of like autoimmune diseases. But again, like this is not the pattern of glomerulonephritis, is not what I would expect from it. But it definitely can go scleroderma renal crisis. So I think that is like where I am at, is that, okay, this is most likely a vasculitis. However, are there any mimickers that I'm missing? And that's when I phoned Rabih MG.
Yeah, I think that, as you said, I think tissue is the issue here, and you want to understand. And I think the disease is definitely existing in the kidney and is being hosted by the glomerulus, very likely. And I think the pattern of kidney involvement will be very, very key. And if you see linear deposition on the kidney, you'll easily ignore an anti-serum, the anti-GBM that is negative. And I think that is a very enticing possibility. I think if you analyze this case and you just say, okay, you know what, I'm going to assume that she has glomerulonephritis. And what could that tell me? I think her age is interesting because it's pretty unusual for ANCA-associated vasculitis to occur in younger people, though it can. So ANCA-associated vasculitis, as you said, 20% of people are ANCA negative. Interestingly, though, the more systemic your disease is, the more and more unlikely it becomes that you're ANCA negative. And she has age going against ANCA vasculitis. So even though it's the most common, the fact that she's young and the fact that she's ANCA negative with systemic disease is intriguing. Anti-GBM disease, the vast majority, about 95% of patients are seropositive, so that's 5%. An intriguing thing about anti-GBM disease is that they only have lung renal syndrome. They don't have epistaxis. They don't have skin involvement. So her epistaxis could just be from uremic platelets and not due to the underlying disease. But that is a point against anti-GBM disease. And I think for me, the only major serological progress you can you can do is to get paraprotein, because monoclonal gammopathies of renal significance can certainly look like this and may explain the cardiac involvement by virtue of cardiac infiltration. And so here, I think we would be assuming that the cardiac disease of diastolic dysfunction is as a result of hypertensive heart disease, but the spectrum of monoclonal gammopathy of renal significance extends from really any age to, I've seen it in a 25-year-old man who had really bad kidney disease. So it's certainly very possible. So I think tissue is the issue, as you said, and SPEP, serum-free light chains, may be the only way that you get a lot of momentum before you get clarity. Zachariah, what an incredible case. Yeah, why don't you tell us more?
So just to reflect on the previous aliquot, we asked radiology to give us a report, a diagnostic report of the chest X-ray, and their report was that the findings are consistent with pulmonary edema and diffuser alveolar hemorrhage. So we couldn't ask them to put their head on the block with a diagnosis, definitive. And also, just to pose a question to you, seeing a patient like this, how would you sort of manage the patient at that point in time?
Yeah, I don't know. I don't think there's a right way to do it. I think the core question, which I'm happy to pose and then both of us answer, is do you give the patient corticosteroids? And I think for me, the answer is yes. I think that the biggest reason not to is the risk of infection-induced glomerulonephritis, which is possible always, but is often, in the vast majority of patients, hypocomplementemic. And the only reason I wouldn't do it is if the blood cultures were positive, if the patient had valvular disease. And so I think the risk benefits of empiric steroids is always a calculated gamble, but given how sick this patient is, I probably would do it. What do you think, Sharmin?
Yes, I agree. Because yeah, I can't think of like an infection mimicker at this point. And I think like endocarditis is relatively, I would be surprised if this turned out to be like kind of an endocarditis given like the complements being normal. So I think, especially given her age, I think it's worth giving high dose steroids to see and use that as kind of a diagnostic tool. Out of curiosity, what was her heart failure attributed to previously? Do you know, Zachariah?
At baseline, she didn't have heart failure. This was an index
This was a new
presentation to
index.
any health
Yeah.
index presentation to any health facility.
Gotcha. Okay, perfect.
Okay, so like Rabih said, tissue is the issue. So we got renal on board and they did a biopsy for us. And the biopsy showed global glomerular sclerosis with mild to moderate tubular atrophy and interstitial fibrosis, no crescents, no immune complex deposits, no primary glomerulopathy. And the vascular findings was extensive fibrinode necrosis, myxoid internal thickening, and near occlusion of the vessels. And the next aliquot will reveal the final diagnosis.
You know, Rabih, I wish I could tell you that means something to me. It really doesn't. So I may need your help to figure out what this finding means.
Yeah, I think that this is a really important distinction, and it really highlights the importance of using the specific terminology of renal vascular disease and always presuming glomerulonephritis until proven otherwise. And I think maybe what I can do is actually, because it's such a key point and we have some time, I'll just try to illustrate a visual. Give me 1 second, because I think this is easier to try to explain with a picture. We've had this conversation in the CP Solvers Academy, so we try to. Okay. So I think what Zachariah is giving us the opportunity to fine tune is, how the heck do you diagnose glomerulonephritis? And the answer is only a biopsy can do it. And he's shown us how close you can get to the diagnosis, but be wrong until you get the biopsy. So as he said, the biopsy does not show glomerulonephritis. So how can we understand that? And for the purpose of making it simpler, I think you can just focus on the left side of the screen and then analyze everything else in detail after this conversation so you have it. But you cannot diagnose, as the Academy members know. I kind of asked them a mean question in the Academy conversation. But you have to have both proteinuria and hematuria. You cannot have glomerulonephritis without both being present. And this patient has both. So this is necessary, but it's not sufficient. How do you make progress towards glomerulonephritis? Is you start to exclude things that mimic it. And the first is that you have no alternate cause to the patient's hematuria. There's no other reason why this patient's bleeding. So if Zakaria said, oh, we ultrasounded her and she has a large bladder mass, well, that makes glomerulonephritis much less likely. The other is acute kidney injury. So the overlap of hematuria and AKI is very, very small. Very, very small. It's basically renal vascular diseases, kidney stones, and macroscopic hematuria causing outflow tract obstruction. Then you get to the smear. So we never got her urinalysis and her smear abnormality showing dysmorphic casts and red blood cells. But even if we did, the only thing that you would diagnose is you would know that her glomeruli are bleeding. So if you ask ourselves, like, what do we know about this patient? We know she has proteinuria and hematuria. There's no alternate cause. She has AKI. So she is bleeding from her glomerulus. And the most common, I think, leap, Sharmin, that we make is we assume that glomerular bleeding is from glomerular vasculitis. But glomerular bleeding can happen from many things. The most common mimicker is that your patient is on anticoagulation and has what's called anticoagulant nephropathy. But a very good reason for your glomeruli to bleed is actually that the arterioles that perfuse them are clotted, and when the pressure builds up behind those clots, noting the title, or I should say, when the pressure rises behind those clots, the glomeruli bleed. Just like, how you were saying, Sharmin, with the haemoptysis, that it can just be from pressure buildup from the heart, the same thing can happen to the kidney.
Yeah.
And so I think the biggest reason to suspect renal vascular disease, the biggest reason to suspect glomerulonephritis being mimicked is, one, it's normal complementemic, and two, that every single test you're doing for glomerular disease is negative.
Yeah.
So I think now the problem that we're trying to solve is essentially a thrombotic microangiopathy of the kidney with secondary glomerular bleeding as a result of glomerular capillary hypertension rather than glomerular thrombosis. So that's how I'd be interpreting this result.
You're the best. No, that's like really, really helpful. So I think in the world of TMA, if I go back and look at the anemia, so now the way I'm thinking about it is okay, if we put the heart aside and let's say perhaps the haemoptysis could have come from the heart and just focus on the kidneys alone with the anemia, LDH, are we dealing with kind of a HUS type syndrome that is causing heart kidney disease? So I think I would lean into the world of hemolysis a little just to make sure we're not dealing with that. And then, as you mentioned, hypertension alone, malignant hypertension can do it. And then the other one is kind of lupus and scleroderma, antiphospholipid syndrome that I think it can do similar things. And I think there's some drug-induced, again, and less likely someone who's never been hasn't been taking any other drugs. And the other thing that perhaps forgot to mention, in a 30-year-old, always get a pregnancy test to make sure she's not pregnant and we're not dealing with a HELP type syndrome, which hopefully not. But I think I would, if this is me taking care of this patient, I would want to make sure, get the smear, making sure I'm not dealing with hemolysis before and thinking about scleroderma, and then kind of contributing it to kind of a malignant hypertension type of a phenotype What are your thoughts?
There with you. I think the problem representation of renal thrombotic microangiopathy is one in which your default diagnosis becomes complement mediated thrombotic microangiopathy. And you can only really prove that with two things. I think genetic testing can help you, along with complicated complement analysis well above just the basic level of C3, C4. So I think if I were just to try to capture your thoughts in the 10,000-foot view of this case, is this patient comes in, she has vessel problems in her nose, in her lungs, and we've essentially really all simplified them to the fact that she has glomerular bleeding. And now we know that she's bleeding in her glomerulus because she's forming so many clots, thrombosing off the kidney vessels distal to them. And so it really becomes, is there any other signal towards an extrarenal disease? And I think the answer to that is no. Everything else we're seeing is a consequence of those clots in those kidneys backing up into the heart, causing essentially a form of nephrogenic pulmonary edema. And probably her epistaxis is easily explained by the fact that she cannot form healthy platelets and is having uremic bleeding. So if we really stick to the problem representation of an isolated renal thrombotic microangiopathy, everything that you said really stands true. And I have it visually represented is you really have to make sure that there's no other overt clue. Like you said, make sure she's not pregnant, which I neglected to put on here, hopefully, because you wouldn't need this to make you wonder if somebody's pregnant. But yeah, you'll have to do all these things that you said. And if it truly is isolated, it becomes a very tricky distinction between complement-mediated TMA or malignant hypertension. And we had a similar case on CP Solvers about how to distinguish these two. And ultimately, I can try to find the schema later, but ultimately trying to distinguish these two is a very, very difficult thing that is probably best summarized by saying we should assume this is complement-mediated thrombotic microangiopathy, but at the same time, aggressively treat the blood pressure. So I think what would I do now is I would really, really try to lower her blood pressure aggressively, but probably also give her a complement blocker like eculizumab and hope for the best that she recovers. Any thoughts or anything to layer upon that?
You're just so brilliant, Rabih. That was awesome. Zachariah, I'm so excited to learn from you.
So yes, the pregnancy test was negative, so it was not anything pregnancy related. And the haemoptysis that she hemoptysized earlier, we sent off a sputum sample, and that had finally returned, and it was positive for Mycobacterium tuberculosis. And the final histological diagnosis on the renal biopsy was severe malignant hypertensive nephropathy.
Oh my gosh, you have a lot of explaining to do, my friend. How are you putting this together?
So when I saw her initially, I saw her in the wards, and that's when she had her episode of haemoptysis. And we always, in our setting, keep TB in mind because it's endemic to South Africa and especially in Cape Town. So she had the classical symptoms, fevers, night sweats, weight loss. So we did send off a sputum. And at the time of my examination, her blood pressure was elevated as well. But she had no history of any hypertensive disease. And this was actually an index presentation to any health facility. So we worked her up, and we were at the point after the chest x-ray returned, and radiology told us that this is either, they said it's diffuse alveolar hemorrhage and pulmonary edema. So we were thinking that this is definitely a rapidly progressive glomerulonephritis. And that's at that point, nephrology was consulted, and they advised that we start her on steroid pulse therapy, which we did, and they prioritized her biopsy. And the biopsy result was in keeping with hypertensive malignant hypertensive nephropathy. And the sputum a few days later returned So putting the whole case together, the sputum returned back as positive for Mycobacterium tuberculosis, which was sensitive to the standard first-line regimen.
Talk too much, Charmy. What are your thoughts? That's unbelievable.
Ah. Oh, TB is my new lupus. You know? Zachariah, what an incredible case. And I think we always try to ground ourselves on like what is common, what is the base rate of disease, and kind of thinking about like practicing in South Africa and what is common, TB, atypical presentation of a common disease. And that will never lay you down in medicine to ground yourself. And that's not what I did when I was thinking about this case. So I think that part of it is quite fascinating. And it's also quite fascinating to think about management of a patient who is at risk of TB and you're worried about an inflammatory syndromes. And from a management standpoint, giving steroids, which again, like I think in a young person coming in with your biggest concern is glomerulonephritis. Hindsight, sure, but I don't think that would have been I would have done the same, basically. I think I would have been worried about a 30-year-old and potentially needing not having a recoverable kidney injury. So medicine is fascinating. I learned a ton. I haven't thought about like malignant hypertension causing a TMA in a while. So thank you for presenting this. Thank you for helping me think through this. And biggest shout out to everyone in the chat and to the one and only RG for always walking me through cases.
Oh my gosh, I think you're too humble, and at the risk of going over long, I'm gonna try to propose a narrative, because I think the facts are that this patient has TB. That's a fact. And the fact is that this is the most unusual presentation of TB that's probably ever been described. So congratulations, Zachariah. I think you hold the record for the most chameleon of diseases presenting in the most unusual way, because I definitely have I've never read or heard about TB showing up in this way. And it reminds me of a patient I saw, and this is going to spoil an academy session, but that's okay. A patient I saw about a week and a half ago who came in and with COVID and came in floridly hypotensive and very ill. And the reason he had a very unusual presentation of COVID is because he had known adrenal insufficiency. And so his presentation of COVID was camouflaged by a severe vulnerability. And so if you take this case from that perspective and you say, okay, let me try to understand what role TB played in the cumulative number of problems this patient has. And I think we are accustomed to saying that TB directly causes all my patients' problems. It causes all the weight loss. It causes all the sputum. It also causes all the cough. It causes all the neurological lung damage. And I think if you ask yourself, how can I implicate TB directly as a cause of the patient's renal function? As far as my current knowledge goes, zero. How can I implicate TB in the cause of the patient's heart failure? Zero. How can I implicate TB in the cause of the patient's epistaxis? Zero. How can I implicate the TB in the case of this X-ray? That's equivocal. Maybe a component of this X-ray, but there's no doubt based on the JDP that there was also fluid in the lungs as well. So if you're being logical about how much of this diagnostic space is being completed by tuberculosis, you might have to ask yourself, well, is this the equivalent of that patient with COVID who has a vulnerability? And I think that's when you ask yourself, okay, well, I think TB unlocked something in this patient, that this patient was more susceptible to the consequences of getting an infection like TB than the other person was. And if you had removed that vulnerability, this patient might not have shown up with her tuberculosis diagnosis for another 3 or 4 months, as is true for most patients with TB. And based on the fact, Zachariah, that you diagnosed tuberculosis with a simple AFB sputum analysis, tells me that her bacterial burden was probably pretty high, which may imply the sort of either exposure that she had, Maybe this is something that you can speak to too, but I'm just so curious about how easy it was to diagnose TB in this case and how difficult it is sometimes. But I think the question is, what is her vulnerability and why is so much of her problems as an indirect consequence of TB? And I think that's where I would really propose the idea for us to be open to her having complement-mediated TMA. And I say that because if we ascribe her massive loss of renal function to hypertension alone, and then I think we will just control her blood pressure at the risk of her kidneys spiraling out of control. And if we review the triggers of complement-mediated TMA, infection is a big, big one. So these patients walk around minding their own business until the moment they get an infection, and boom, they get a complement-mediated TMA. And I would be suspicious of that primarily because this is an otherwise 30-year-old woman who has no secondary cause for hypertension. She doesn't have hyperaldosteronism. She doesn't have Cushing's disease. She doesn't have a pheochromocytoma. She doesn't have coarctation of her aorta. So why she would be all of a sudden in such hypertensive crisis to infarct her kidneys and, curiously enough, not affect her brain, seemingly not affect her eyes, seemingly is very peculiar. And so there's so much literature now in the last 2 or 3 years on how complement-mediated TMA has been for many, many decades erroneously labeled as malignant hypertension. Yeah, I'm really, really curious how you were thinking about that. And I know it's a relatively new conversation we're having, so I'm not certainly an expert in it. I just know to ask the question. I'm really curious what your thoughts on it are on it, Zakaria.
So this patient was followed up by nephrology and was worked up for extensively for secondary causes of her hypertension. And based on all the findings together, the echo showing that this is long-standing with already target organ damage, and the renal biopsy in keeping with features of chronic kidney disease, the thought was that these were two separate pathologies and not necessarily an atypical presentation of TB, rather typical presentation of pulmonary TB and typical presentation of a hypertensive, what we call a hypertensive crisis, a malignant hypertension. So there was a lot of reflection for me for this case. And I mean, we usually think that Occam's razor, it's best explained by a single explanation, or things are best explained by a single pathology. But I mean, this was a clear indication that we should always think of simultaneous pathology and two typical presentations of two typical cases. And also, I did some reading around blood pressure, the accuracy of the automated blood pressure monitors as compared to the gold standard mercury column manometer. And it showed that there was a lot of inaccuracy around the automated blood pressure manometer. And as evidence here, her blood pressure was 172 over 105. And as per guidelines universally, I think we'd say a hypertensive crisis is more than 180 systolic and 110 diastolic. So there was a lot of reflection for me in this case.
I don't know what to say, but just to thank you. I think that you brought so much learning to us, and I'm very, very, very grateful for it. And the hypothesis that she has had many of these abnormalities for a long period of time, and all that was new on your watch was tuberculosis, is a very, very intriguing one. And I think that yeah, I'm very, very intrigued. I'm curious, just for a closure, do you know how she did and what happened to her renal function over time?
So she did well. She was followed up by nephrology, and her renal function significantly improved on antihypertensives and anti-tuberculosis treatment. 2 months later, I think there was significant improvement in her renal function.
And did she need dialysis at all? Or was she lucky enough to be dialysis?
No. So she didn't need any dialysis throughout the course of her admission. And her urine output was above a liter a day.
Oh my gosh, I don't know what to say. I think my mind is like 5 miles from my body right now. Good thing we're on vacation, Charmaine, to process this case. So thank you so much, Zachary. Yeah.
I'll be texting you about this case for the
Oh
next
my
few days,
God.
Robbie. Just FYI. Sorry you're on vacation.
Oh, it's all good.
Yeah, amazing. Thank you.
Big shout out to you. Thank you so much for really. I've learned a lot already, but I can't imagine all the learning coming our way and as we fine tune the reflection from this case. I hope your appetite for diagnostic mysteries remains, but hopefully your journey will not be disappointing because I think most diagnostic mysteries that exist in the world fall far short of how intriguing this was. So I hope your appetite remains strong, even though you've probably experienced one of the most intriguing ones to date. So thank you.
And come back soon.
He's coming back next week. Oh my gosh, if this was the first, I can't imagine. I'm not coming Friday. I'm just gonna sit in the audience. Alrighty, Julia, take it away, please.
Guys, to be honest, I was just thinking how to summarize this case in my mind, and I'm so mind blown and so humbled. And I think anything I would say would simplify that case so much and leave out the main learning points. I feel you guys, it was such an amazing case that the only thing I think is left for me to say, watch this video again. Please, Zach, come back and do a lot of reflections on this case. And I think the main takeaway I had was really thinking about like reassessing all the findings and be able to dissect whether the findings are consequences of the syndromes we have, or rather one like puzzle or one like symptom of it itself. And I think the way you guys dissected it was just amazing, and I feel I don't really want to mention any like little learning points because this case was so amazing that I think the main takeaway really is to be able to do your step back and just reassess and thinking about consequences or like symptoms of a syndrome. And I think Zach, please come back. There's so much reflection going on in my mind. And I do need holidays as well, I think, to process this case. So thank you so much.
Final word to you, Charmaine.
Always an absolute pleasure. VMR is the best hour of every day. That's all I have to say. And it was so fun discussing with you again, Robbie. All right. Bye, everyone. See you later. Bye.